Standard treatment workflow. Immunobullous dermatoses. When to suspect. Appearance of fluid-filled, itchy or painful blisters, either flaccid or tense on skin over a normal or erythematous base. Appearance of raw erythematous erosions with or without crusting on skin. Appearance of erosions, blisters inside oral cavity, eyes, nose, and genitals. Autoimmune blistering diseases. Pemphigus vulgaris variants, Pemphigus foliaceus variants, Bullous pemphigoid, Pemphigoid gestationis, mucous membrane pemphigoid. Linear IgA bullous diseases, chronic bullous diseases of childhood, dermatitis herpetiformis, epidermolysis bullosa acquisita, bullous systemic lupus erythematosus. Additional information: age at onset and duration of blistering, history of any recent drug intake, history of prior varicella, chickenpox, history of similar illness in family, history of itching, pain, burning, predominant sites affected, associated photosensitivity. When to suspect. Are the blisters flaccid or tense? Are the erosions crusted? Do the blisters contain clear or hemorrhagic fluid? Are the blisters umbilicated? Is the base of the blisters erythematous, urticarial? Are the blisters healing with or without scarring? Are they healing, leaving behind hyper or hypopigmentation? What is the color of the crust? Are mucosae involved? Diagnosis of autoimmune bullous diseases. Likely pemphigus group of autoimmune bullous diseases. Flaccid blisters or erosions with or without crusting on skin, with or without mucosae involvement. Usually seen in adults, can rarely affect children. Likely subepidermal autoimmune bullous disease. Tense, small to large blisters containing clear or hemorrhagic fluid on an itchy erythematous base, commonly healing with hypopigmentation with or without scarring. Seen in children, adults, and elderly. Most common is bullous pemphigoid. Get a Sank smear, get a biopsy for histopathology from margin of a lesion, get a perilesional biopsy for direct immunofluorescence if facility is available. Child under the age of 5 years, erosion with peripheral tense blisters, urticarial base, face, or perigenital involvement. This is chronic bullous disease of childhood. Red flag signs: fever with or without chills and rigors, hypotension indicating hypovolemia due to loss or sepsis, altered sensorium indicating dyselectrolemia or sepsis. Differential diagnosis: bullous impetigo, varicella, Stevens-Johnson syndrome. Epidermolysis bullosa, a hereditary blistering disease with onset in neonatal period or infancy and predominantly affecting pressure sites. Presence of scarring on limbs, acral areas, trunk, and abnormality of the teeth or nails. Consider congenital syphilis in a neonate. Get VDRL for mother and child. Refer to STW on bacterial infections, varicella and herpes zoster, and CADR-RB. General measures: monitor temperature, respiratory rate, pulse rate, administer antibiotics if lesions are infected with and foul smelling, fluid electrolyte balance, get hemogram, basic biochemistry including renal and hepatic function tests, blood sugar, get pulse culture, and if sepsis is suspected, also blood culture. Supportive management: clean, non-adherent dressings, maintain hygiene with normal soap bath, topical antibiotics, aspiration of large blisters with 18G needle if needed. Avoid de-roofing the blisters as the roof of the blister acts as a natural dressing. Maintain oral health. Chlorhexidine mouthwash. Brush teeth with pediatric brush with small head and soft bristles, avoiding eroding gingival margin. Maintain skin hygiene. Diluted potassium permanganate bath or potassium permanganate compresses on localized lesions or thick crusted lesions. Emollients or coconut oil application. 2% Savlon scalp wash. Encourage oral intake. Consider other comorbidities. Liquid or semi-solid diet for oral erosions. Pemphigus. Start treatment only if facility for monitoring and management of complications of treatment is available. Mucosal or mucocutaneous with body surface area less than 5%. Oral prednisolone 0.5 mg per kg per day with one or more of the following: azathioprine 2 to 3 mg per kg per day, mycophenolate mofetil 35 mg per kg per day, start at a lower dose, cyclophosphamide 1 to 2 mg per kg per day, methotrexate 0.3 mg per kg per week, dapsone 100 to 150 mg per day. Mucocutaneous with body surface area more than 5%. At primary level, stabilize patient, initiate general measures and refer to a specialist or tertiary level. To be managed at a tertiary level, dexamethasone, cyclophosphamide, pulse therapy, rituximab. Bullous pemphigoid, start treatment only if facilities for monitoring and management of complications of treatment is available. Limited 10%, less than 10% of body surface area. Start treatment and refer to tertiary level. Topical clobetasol propionate up to 30 gram per day. Oral prednisolone 0.5 mg per kg per day with or without dapsone 100 to 150 mg per day, doxycycline 100 to 200 mg per day, niacinamide 500 thrice a day, azathioprine 2 to 3 mg per kg per day, start at a lower dose, mycophenolate mofetil 35 mg per kg per day, start at a lower dose, methotrexate 0.3 mg per kg per week. If extensive, more than 10% of body surface area, to be managed at a tertiary level. Oral prednisolone 0.75 to 1 mg per kg per day with or without dapsone, doxycycline, niacinamide, azathioprine, mycophenolate mofetil, methotrexate. Correct diagnosis, prevention, treatment of sepsis, and regularity of treatment brings best result.